Okay, let's start with Chapter 18 today, looking at urinary system disorders. And what we'll be looking at, we're going to start with some review first. We'll start with review of some of the basic anatomy of the kidney and nephron and some of their basic functions because it'll help you understand what happens when there's damage to any part of the kidneys. So we will talk about cystitis and compare it to pyelonephritis. We'll talk about acute post-streptococcal glomerulonephritis. Then we'll discuss nephrotic syndrome. We'll talk about urinary tract obstructions, and we'll talk about the common causes of urinary calculi or kidney stones. Then we'll talk about hydronephrosis. We'll discuss adenocarcinoma of the kidney and bladder. Then we'll talk about nephrosclerosis, right? Sounds like hydronephrosis, but they're not the same thing, right? So hydronephrosis and nephrosclerosis. Then we'll talk about polycystic kidney disease and acute and chronic renal failure. So before we get started, let's talk about what are some of the basic functions of the urinary system. Well, it helps us remove metabolic wastes. It removes hormones from the body. It helps to eliminate drugs and foreign material from the body because after the liver does its thing in phase 1 and phase 2 of liver detox, then the kidneys in phase 3 help to remove all of those toxins. It's involved in water regulation, electrolyte balance, acid and base balance. It's involved in secreting erythropoietin. It activates vitamin D, and it's involved in regulating blood pressure through the RAS system, the renin, angiotensin, aldosterone system, RAAS, the RAS system. So the main parts of the urinary system, the kidneys, the two ureters, the urinary bladder and urethra. The way to remember the difference between the ureters and urethra, remember there's two E's in ureters, there's two kidneys, there's one ureter attached to each kidney, so there's two ureters, one urinary bladder, and one urethra. Urethra only has one E, so there's only one of them. So here we have the two kidneys, the two ureters, then we have the urinary bladder and urethra. That's true for male and female. The size and width and length of the urethra is different for males and females. The kidneys are retroperitoneal. So you can see here, you have the renal fascia, you have adipose capsule, there's a renal capsule, and here, it says right kidney, but it's really the left kidney, because here we're looking at anterior, this is posterior, here is the vertebral body, the spinal cord, so this is really the left kidney. So it's retroperitoneal, it's behind the peritoneal cavity. All right, the indented area right here where the entrance of the renal artery, vein, nerves, lymphatics, and even the ureters where it enters or exits the kidney is called the hilum. Okay, so there's the renal artery, vein, ureter, nerves, and lymphatics. This is what it looks like on a real kidney. The main parts you should review from A&P, the outer part is the cortex, the inner part is the medulla, and here there are millions of nephrons, which is the functional unit of the kidney. This is where you have the filtration and the reabsorption and excretion or secretion and the urine production. Eventually all that stuff takes place here in the nephron, and then it's dumped in a minor calyx, major calyx, renal pelvis, and then out to the ureter. The blood supply to the kidneys, although the kidneys constitute less than 0.5% of the total body mass, it does receive about a quarter of the resting cardiac output. In terms of neurological supply, The renal nerves primarily carry sympathetic outflow. When the sympathetics are stimulated, then the arterial system, the blood supply, constrict. So they regulate the blood flow through the kidneys. As the blood flow from the abdominal aorta into the renal artery, it then follows the path that we can see to the right into the segmental interlobar, which is here. Then you have the arcuate arteries, and then radiating into the cortical region is the cortical radiate arteries. And then off the cortical radiate arteries, we end up having an afferent arteriole that leads into the glomerulus, right? This is where you have the glomerular capillaries. Then you have an efferent arteriole leading the blood out, and then it leads into the peritubular capillaries, then into the peritubular veins, and then the similar structures, instead of the arterial side, it's in the venule side, the cortical radiate vein, arcuate vein, interlobar vein, renal vein, into the inferior vena cava. This is just another way of looking at it. After the cortical radiate, blood goes into the afferent arteriole. You can see this is wider and larger, and then it leads into the glomerulus, and then blood goes out through the efferent arteriole. This is a little bit wider, so blood can rush in. This is a little narrower, so it slows down the rate of filtration in here. And then it starts to pull out all of the debris through this filtration system. Whatever is pulled out is called filtrate, and then it moves into the first part of the tubule, the proximal convoluted tubule. Then it goes into the loop of Henle, to the distal convoluted tubule, into the collecting ducts, and then out. If this is dilated and this is really constricted, then the filtrate is pulled out, and it takes a while for it to get filtered. They call that glomerular filtration rate. Okay, and there's different ways of speeding that up and slowing it down. Right in here is a region called the juxtaglomerular apparatus, where we have juxtaglomerular cells here, and then we have macula denser cells here. This is part of the distal convoluted tubule. This is the proximal convoluted tubule, and at the other end is the distal convoluted tubule. And right here is a bunch of sensory receptors that kind of measure what is the oxygen levels like, what is the blood pressure like, and based on what's happening as blood is traveling through here, your body can react and respond in different ways using different hormones to allow glomerular filtration rate to increase or slow down, for the body to push out erythropoietin, or to slow down, or renin, or to inhibit that. Okay, so we're going to take this section here where you have the medullary, the medulla, and then the cortex. So right here is the medulla, here's the cortex, and we can see that this is just one of the millions of nephrons that exist. Here we can see we have the glomerulus, we have Bowman's capsule, we have these tubules, we have blood vessels and a capillary system going around it, and eventually, as the blood starts to be filtered, as the blood comes in, you have filtrate that moves down through the proximal convoluted tubule, loop of Henle, distal convoluted tubule, and at any point through here, we have, it's like a two-way street where you have solutes that can be pulled out of systemic circulation and pulled into the tubules for excretion, or maybe things were in the filtrate, and then your body can actually bring it back into systemic circulation if it should. And then out through here we have the urine that's actually ends up being formed, okay, and excreted or secreted. So at the nephron, we have an afferent arteriole, an efferent arteriole, and what's happening at the glomerular capsule or the Bowman's capsule, you have filtrate that's pulled out. So you have filtration that takes place, there's tubular reabsorption. All along the renal tubule and collecting duct, water, ions, and other substances get reabsorbed from the renal tubule lumen into the peritubular capillary. So we can see at number 2, it's pulled this way. And at other parts, it can actually go, okay, we don't need that anymore, let's get rid of it. And then it's secreted or excreted from the body. So it's filtration, reabsorption, and secretion, which means eliminating. When we say reabsorption, you're reabsorbing it back into blood supply. Homeostasis requires the kidneys to maintain relatively constant glomerular filtration rate. If it's too high, then the substances pass too quickly and they're not reabsorbed. If it's too low, nearly all the reabsorbed and some waste products are not adequately excreted from the body. What are some of the differences between male and female? Well, let's take a look at the anatomy. On the left is the male, on the right is the female. We can see that we have the shaft of the penis here. We have the testes, the epididymis, the vas deferens. This is all reproductive portions. This is not urinary. However, here's the pubic bone, here's the urinary bladder, and then here's the prostate gland. So when the prostate swells, it can constrict the prostatic urethra. So the male feels like he has the urgency that he has to go urinate, but because this is blocked off, he can't. Okay, and then here is the spongy urethra here. So the urethra in males is much longer. Okay, the urethra is 5 times longer in males than in females. The urethra is divided into 3 sections in the males, but it is only one short tube in the female. The urethra is the common duct for the urinary and reproductive system in males. So here is the seminal vesicle, and as semen is released here, this is the same duct that urine flows through and sperm, okay, and semen. Okay, so in the female, here's the urinary bladder, and then here's the urethra, much shorter. And then here is the uterus, and then back here, here's the colon, and here's the rectum and anus. So what happens in females, females have to be real careful when using the restroom and wiping, always from anterior to posterior. Always wiping anterior to posterior. If wiping posterior to anterior, the chance of bringing bacteria into the vaginal area and getting an infection are very, very likely. It's very common in women. So again, just another schematic that shows how there is an afferent arteriole, an efferent arteriole, and then these blood vessels follow all the tubules, so there could be a two-way street at any pathway. But there's filtration, reabsorption, and secretion that takes place. Some of the hormones involved: ADH, aldosterone, ANP, antidiuretic hormone is secreted by the posterior pituitary, and it's involved in the reabsorption of water in the distal convoluted tubules and in the collecting ducts. Aldosterone, which is secreted by the adrenal cortex, this is involved in sodium reabsorption in exchange for potassium. So we hold on to sodium, you hold on to water, and the person doesn't pee, right? No urination. Antidiuretic, against losing the water. ANP, atrionatriuretic hormone, is a hormone from the heart, and it reduces sodium and fluid reabsorption. So this one is just the opposite of aldosterone. Aldosterone's holding on to it. The heart's like, not going to happen. Let's get rid of it. This just shows what controls glomerular filtration rate. So here is normal filtration, where you have blood coming in and blood coming out. And here's the glomerular capillary system. This is the Bowman's capsule. And filtrate is pulled out into the proximal convoluted tubule. Here, this is showing the afferent arteriole is dilated, so it's really rushing and bringing blood in, and we have a little bit of constriction of the efferent, so it comes in much faster than it can leave, and that's a dilated blood vessel. Okay, here on the bottom left, we say a vasoconstricted efferent. So blood comes in, it can't come out as quickly, so um, it slows the rate at which it can leave, and it increases the time here in the filtration system. So we have increased filtrate that's pulled out if there's more filtration time. Here we have decreased filtrate because the sympathetics must have kicked in and renin must have done its thing, because we have a vasoconstricted vessel here and vasoconstricted vessel here, so the amount of filtrate that's pulled out is decreased. So the sympathetics are involved. They can vasoconstrict the renin, which is secreted by the juxtaglomerular cells when the blood, right? So when, I think I showed on that other picture where the afferent arteriole is and the distal convoluted tubule, we have the juxtaglomerular cells. So renin is actually secreted in that portion of it. And then that's involved with the RAS system, the renin, angiotensin, aldosterone system. Let's look at some of these terms: incontinence and uresis. Incontinence is the loss of the voluntary control of the bladder, and uresis is involuntary urination by the child older than 4 years old. So what happens when children, as they age, the frontal lobe of the brain becomes much more mature, and the frontal lobe has a lot to do with inhibition. It slows down the heart rate. It makes the child aware that they have to use the bathroom. When the frontal lobe isn't developed, there's no control of those things, and that's why babies wear diapers. They pee and they poop without voluntary control. But as the brain develops and the frontal lobe becomes more mature, the child should get the signals that, uh-oh, I have to go to the bathroom, that type of thing. Stress incontinence, more common in women. It's when there's increased in intra-abdominal pressure, like coughing, laughing, or heavy lifting. Can happen in multiple pregnancies as well. Overflow incontinence is when there's an incompetent bladder or an incompetent sphincter. It happens in older adults when there's weakening of the detrusor muscle. That can happen, or if there's injury to spinal cords or even to the brain. Retention is the inability to empty the bladder. This can happen if there's spinal cord injury or even after anesthesia. And there are some pain medications that do this, and that's why it's really important to know. I had one, I think I discussed it in an earlier video when we talked about pain and infections, where he was on some pretty strong painkillers, and he had to go, but he couldn't, so he had the stagnation of urine in the bladder, and because he couldn't void, it led to an infection that ended up spreading into his bone. Some of the diagnostic tests, there's urine analysis. We can look at the color of the urine. We can look to see if it's cloudy, if it's dark, if there's an unpleasant and unusual odor. All of these have different indications. If it's cloudy, it could be indicative of protein or blood, bacteria, and pus in the urine. If it's dark, it could be hematuria, could again be blood in the urine, excessive bilirubin, or it's just really highly concentrated because they are dehydrated as well. If there's an unpleasant odor, it could be an active infection, or it can also be a result of some medication. Under a microscope, you can see that there is the presence of gram-negative or gram-positive organisms here, right? This should not be visible under the microscope. Blood, hematuria, if they're small amounts, could be an infection, inflammation, possibly a tumor in the urinary tract. If it's large amounts, then it's going to be increased glomerular permeability and hemorrhages. And we'll get into glomerular permeability. Elevated protein levels, that's called proteinuria or albuminuria. If there's the leakage of albumin or mixed plasma protein into the filtrate, we'll call it proteinuria or albuminuria. Bacteriuria is bacteria that's in the UTI, which can, in the urinary tract, which can be a cause of a urinary tract infection, either of the upper or the lower urinary tract. Other tests, we can look at elevated serum urea and creatinine levels, which could indicate failure to excrete nitrogen waste products caused by decreased glomerular filtration rate. They'll look at BUN as well, bilirubin, urea, and nitrogen. It's called a BUN, B-U-N. Anemia indicates decreased erythropoietin secretion and or the bone marrow is being depressed. Electrolytes are important and can be checked. The antibody levels can also be checked, and elevated renin levels. So there's a multitude of tests that could be done. They'll do cultures as well. They'll do some radiological tests like MRI or angiography, ultrasound, CAT scan, and all of these are used to visualize the structures and any type of abnormality that could be impeding the flow patterns and the filtration rates. They'll look at the clearance of inulin or creatine. They'll use that also, another method to assess the glomerular filtration rate. They'll use cytoscopy that visualizes the lower urinary tract, and they can also do biopsies, as they can with any tissue. In terms of medications, there's a classification of diuretics, which is typically used to remove excessive sodium and water. Some of these diuretics can be potassium wasting, and then some are potassium sparing. And I think I spoke about this also when we did the cardiovascular system, that when you lose potassium, there could be some detrimental effects to the body because it's a major electrolyte. So they make these potassium sparing diuretics, which work but not quite as good as the other ones. These are, Lasix is one of the biggies. Aldactone is another one. Diamac. So these tell you their primary actions and their use. But these are just a few examples of some of the common diuretics. This is also a biggie that is used, especially with hypertension and cardiac heart failure. We see this a lot in patients. Dialysis provides filtration. So if someone's if they have a kidney that's removed, or they're waiting for a kidney transplant, or the kidneys just aren't functioning very well, then they'll go for dialysis, which is designed to help sustain life during the kidney failure. It's used to treat patients with acute kidney failure or for people at end-stage renal failure. There's two forms of it. There's hemodialysis and peritoneal dialysis. Hemodialysis really is using a machine where there's a semi-permeable membrane outside of the body, and the peritoneal dialysis uses the peritoneal cavity as that permeable membrane. Okay, when we come back, we'll start some of the urinary tract disorders, and we will start with infections and inflammatory disorders.